Hi, this is Brian Kim. I want to share with you this interesting case where I was trying to do hydrodissection, and I guess there was a bubble inside the syringe, and suddenly there's this huge bubble that shows up underneath the lens and within the capsular bag. And so it was kind of a shock. So I'm going to show you what happened and just kind of pose a question. How do you handle this situation? Once that bubble was in there, I had to figure out how to get that bubble out and then proceed with the cataract surgery. So this is a patient's eye. I'm using the cotton tip to steady the eye, and then I'm using a corneal marker, which will help me to center and size a rhexis. Again, with that same cotton tip, I want to make a paracentesis incision, first on the right side and then the left side, making sure I'm flat to the iris plane, which will allow me to create a nice corneal shelf and achieve a self-sealing incision. As you can see, there are some marks on the cornea, and that's going to be for the toric lens. I'm injecting some intracameral lidocaine and then some intracameral epinephrine, and then I'm injecting a bubble for the trypan blue. This patient has a little bit of a whitish cataract and kind of a hazy view there. The bubbles didn't consolidate to one bubble, and so I'm just doing the best I can, trying to sweep around. The visibility is not great. So I go across with a cannula and push some dispersive viscoelastic, which causes the dye and the bubbles to come out. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, controlling the eye with the cannula. Once I'm made my tunnel, I turn the eye towards me and then I enter. So this patient has quite the elastic capsule, and so I decided to go ahead and use the cystotome to puncture. So I puncture the center, go a little bit to the left, pull down to create a little bit of a flap there. Go ahead and remove those bubbles with the cannula. Grabbing the flap. The view was a little bit obstructed, and so I asked the technician to drop some BSS as I went around. This patient is a high myope, and so as you're manipulating, it can cause some corneal stria. And so by dropping some BSS, it helps with the view. So in these high myopes with kind of a more prone to soft scleras and corneas, if you find that you have corneal stria, you can drip some BSS slowly during the maneuver, and it keeps the view a little bit clearer. So that's a little bit of a small pearl there. So this is it. I want to do the capsular fornix hydrodissection technique. I place a cannula out under the rhexis edge, point the tip down, and look what happened. This huge bubble. In fact, that's all that came out was air. I don't think there was any BSS that came out. So I go under the rhexis edge, contra-incisionally, get to the capsular fornix. You see the little nudge, point the cannula tip down. Instead of BSS causing a wave, a giant bubble is formed. And so this is a testament to capsular fornix hydrodissection technique. It's really a very reliable and predictable technique, and you saw that bubble just went right back. So now I'm going to have to find a way to get that bubble out. And so you can see I'm using the cannula, trying to nudge the lens, tilt the lens to get that bubble out of there. Now this is a little bit of a soft lens, and so as I'm doing the maneuvers here, the lens material is kind of cheese wiring with the instrument's manipulation. But you see a little bubble comes forward. And I decide, you know what, let's just go ahead and move forward. I got that one bubble out. I don't feel like there's significant pressure causing distension of the capsule or anything like that. So I go in, lift the incision, go in with irrigation off, activate irrigation. And as I start, you can see there's small bubbles that are coming forward, and I just aspirate those bubbles as I go. And there's some more bubbles that come out. So now the bubbles are basically all out. But you can see the lens is tilted. It's not in its normal position when I go ahead and do the double chop and cross chop. And because of that, all the landmarks are distorted. The lens is tilted. It's really hard to tell where the endonucleus and epinucleus starts. And so you can see I'm trying to get around the lens, trying to get a feel for how I can chop this lens, but I can just sense I'm not really around the endonucleus. So you can see I'm doing the chop maneuver, but nothing's really happening. And I'm also being quite conservative because, again, my landmarks have all been distorted with that bubble. So here I'm just trying to grab the edge of the lens, see if I can lift it up, but the lens just slips back into the capsular bag. I'm trying to manipulate the lens here. So right there, I finally make a chop maneuver, and I can feel that I get around the lens, and I'm able to fracture the lens in half there. Starting to emulsify that piece. I turn that second heminucleus in front of me, placing the chopper around the lens, pointing the phaco tip vertically subincisionally, and I'm able to fracture that second heminucleus in half. Use some vacuum to grab the piece, and then crushing the lens into smaller pieces and emulsifying the lens pieces. So the actual endonucleus is pretty thick. You can feel it's a little bit of a nugget there. I'm having to use quite a bit of force to crush the lens into smaller pieces here. So now I'm just tilting up that piece with the chopper. It's sitting more vertical now, that piece, up and out of the bag. And now I'm able to sandwich it with the instruments, just crushing it again, using some vacuum to grab the pieces and then emulsifying the lens pieces. So that's basically the endonucleus now. I got it all out. And I'm going to grab the epinucleus, starting from the anterior side, and it starts to prolapse up. I always keep the chopper deep to protect the posterior capsule in case it wants to fly upward. Grabbing the edge of the epinucleus subincisionally. It's a little bit of a thick epinucleus there. And then now it's out. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start subincisionally, removing the cortical material from anterior to posterior, going around circumferentially in the same manner, feeling it from front to back, which is a cleaner removal of the cortex. Switching to polish mode, polishing underneath the rhexis edge, removing any cortical material and lens epithelial cells. Go ahead and fill the capsular bag with some cohesive viscoelastic and polishing under the rhexis edge with the sweeper. First on the left side, you can see there's a little bit of lens material that's coming out as I'm sweeping the subincisional space, and then I'm sweeping on the right side. Go ahead and inject the single piece acrylic lens into the capsular bag. The leading edge goes into the bag. As the lens unfolds, I go ahead and use the sweep to disengage the haptics. I go in with the INA tip with irrigation off, and then activating irrigation, going underneath the lens, tilting it and rotating it, removing the viscoelastic from within the bag. I'm positioning the lens again because this is a toric lens. I'm using the cannula tip to nudge the lens into place and in the correct axis. I'm polishing underneath the rhexis edge, removing the viscoelastic from the anterior chamber. I'll make sure the position and axis is correct, and then I'll hydrate my incisions. So again, this is a kind of a unique case. I rarely have bubbles when I do hydrodissection, to be honest with you. But in this case, this was kind of a surprise because it wasn't even a small bubble, it was a giant bubble. And so I'm actually relieved and shocked that it didn't actually bust open the posterior capsule. And so what apparently happened was as the bubble went in, it just caused the lens to go up. And so it created a little bit of space. Yes, it caused the posterior capsule to be distended, but the lens was able to go upward. And because it was a softer lens with some soft epinuclear material, it was able to tolerate that bubble and it didn't cause too much stress on the capsular bag. And so you saw we kind of gently tried to lift the lens and tilt the lens to allow that air bubble to come forward. There's really no easy way to get that bubble out. And so thankfully I could sense there was not much, capsular bag distension or tension. And so we went ahead with the phaco tip. So what it did was when I went in with the phaco tip, that increase in irrigation pressure, the IOP pressure, it caused the intracameral pressure to increase. And as a result, when I was able to tap on the lens, it did allow that lens to be pushed downward. And by being pushed downward, it kind of encouraged that air bubble to come out of the capsular bag. And once all the bubbles were removed from the capsular bag, you can see that the lens was not sitting in a normal position where the lens hasn't been disrupted. And so you saw I had to very patiently but carefully position the lens so I can actually fracture the lens in half. And so with patience and with multiple efforts, I was able to finally bisect the lens completely in half with a double chop maneuver and then emulsify and remove that fairly dense central nugget in the center. And after that, the remainder of the case went fairly smoothly. And you can see now I'm positioning the lens. I'm checking the lens for appropriate alignment, and the patient did quite well. So I hope this was helpful to you, and I thank you for your attention.